Hello and welcome to this evening's webinar. Thank you all for joining us today. My name is Hannah and I'm Referral Coordinator here at VVS. I will be introducing our speaker for this evening, Dr Stefanie Mitze, as she presents sleep disorders and gastrointestinal issues in brachycephalic dogs. For those of you who are meeting the virtual veterinary specialists for the first time this evening, welcome and we hope you enjoy today's webinar. Here at VVS, we have a team of friendly, knowledgeable veterinary specialists whose mission is to improve your access to specialist veterinary healthcare, increasing collaboration between first opinion vets and specialists in the industry. With our sophisticated video and diagnostic platform, we empower first opinion vets to deliver specialist level care to their own patients in their own clinics. At a time where the UK pet population continues to grow, with the availability of referral centre appointments limited at this time, the pressure on primary clinics is being felt across the country now more than ever. Rest assured that VVS specialists continue to be on hand to support your veterinary team, your patients and their owners with affordable and timely help. We have also recently launched our Halter monitor service, expanding further the virtual support available from VVS. This allows us to provide seamless continuity for your VVS cardiology referral patients requiring at-home ECG monitoring. Our VVS halters are couriered out to your practice with full instructions and support on fitting and removal. And then all recordings are analysed and reported by the VVS team of cardiology specialists, ensuring not only case continuity, but easily accessible and tailored follow-up support. It is now my pleasure to introduce Dr Stefanie Mitze, our CVS and European specialist in veterinary internal medicine, as she discusses sleep disorders and GI issues in our canine brachycephalic patients. So Stefanie graduated in 2010 before working in a number of referral centres in Germany. Steph completed her residency in small animal internal medicine and then moved to the UK in 2018, where she continues to work in a large referral hospital alongside her work here at VVS. Stefanie's passion for all aspects of internal medicine is clear to anyone who meets her, as many of you have already, but her particular interests include endocrinology, gastroenterology, nephrology, haematology, and hepatology. So combine this with her passion for supporting colleagues and her drive to make specialist input easily accessible to the veterinary community. She's the perfect match for the team here at VVS. And it's an absolute pleasure to have her with us this evening, presenting this topic for us. So before I hand over, just wanted to mention, if you do have any questions about anything that's presented to you this evening, please feel free to pop that in the chat box and we'll have a Q&A session at the end where Steph can answer any questions that you might have. Okay, so I will now hand over to Stefanie.
Thank you so much for this lovely introduction. I'm deeply honored that you give me your free time, spend time with me tonight about this super exciting topic. And I'm absolutely sure you are here because you already had a lot of experience with all these problems in the past and maybe also a lot of frustration. So this is my personal experience, medical point of view from a BOAS patient. I'm honest with you, I was a bit pushed into this topic because I worked with many soft tissue surgeons, which actually were a bit specializing in BOAS cases. And already it's scary, isn't it, to have a soft tissue surgeon who is specializing in improving a malformation. So you know already something is not right. However, these patients always came with additional problems. And this is where I was basically involved. I wonder what you think after this talk about brachycephalic breeds. And I personally must say, the more I read about it, the more I'm shocked, the more I think this must not continue. But I'm already going a bit ahead of myself. I hope you can make up your mind after this talk how to approach this breed in the future and what you think about this in general. I have nothing to disclose. Before we start, I would love to share my understanding of BOAS. And of course, there are so many definitions, and everything is, of course, all over the news and press. So BOAS is everywhere, right? So, of course, you all know it's a congenital malformation with mainly respiratory signs. Why is that? Because bones are shortened and not soft tissue in this case. So the head is shortened with bony structures only. This problem leads to an upper airway obstruction. Makes all sense. What is the other problem? It is a serious animal welfare issue. Why is that? So we have so-called primary lesions. Primary lesions means they're usually always there, and they lead to the secondary lesions. As soon as secondary lesions are there, the prognosis is usually already guarded. Okay, there are various reports who list primary lesions, and some include some things more than the others. But what we do know, classic, is the nostril stenosis. You all know that it's the elongated and thickened soft palate, and even the tracheal hypoplasia. These are considered primary lesions. The secondary lesions makes all sense. Over time, they develop the laryngeal collapse, worst case scenario, the eversion of the laryngeal circles, and so on. So these are all secondary lesions. The impact is so severe that we know now that the average lifespan in these breeds is reduced by 3 years just having BOAS, even though you don't hear a severe breathing sound. Just the malformation is enough to reduce your quality of life and life expectancy. And now my question as a medic is why, if they apparently are healthy, why do they live so much shorter? This drew my attention. I started reading about this, and I will show you in the following slides what I found out. One part is there is an enormous amount of literature out there, and we are all aware that they can't breathe. There is, however, also a big paradox, and this has even been published in scientific studies, that we know that, but the popularity is increasing. So I'm not sure if you ever wondered what an average dog owner wants. And now the question is, what does a brachycephalic dog owner want? And here's the interesting result from these studies. So 60% roughly of owners want a healthy dog, which I think is already pretty low, right? So 60%, I mean, as an owner, I want a healthy dog, right? But the brachycephalic dog owner, they are not interested in that. They are now, in comparison to 10 years ago, they are fully aware that they have breathing problems. They know that. When I started as a vet, they didn't know, they were surprised. Now they know it. They still choose this breed on purpose because of their appearance. They want this childlike cuteness, the big head. This is stimulating us in so many ways. And this is important for us to consider in our communication when we talk to the client. The expectations are completely different. It scares me that there is literature out there. People are aware of this and they still take this into account, okay? So this is about the owner. If you give me a minute to think about ourselves as vet, I want to ask you for a quick challenge if you are okay with that before we dig into the deep, okay? So we imagine the following situation. You are in a waiting room area. Maybe you are hiding behind the reception, what we usually do. Let's say it's a very busy day, and because someone mentioned the Q word, it of course suddenly exploded. So you had no time to eat, you had no time to drink, and you see there is this dog coming in. Let's say it's a warm weather. Let's say this is a brachycephalic BOAS grade 2 to 3. You hear already the loud breathing sound. It's very loud and it's very hot. The dog is panting. He's coming for a routine situation, whatever. What will you do? Will you prioritize this patient? Or will you go step by step by step by step through your diary? Now imagine the same type of breathing in your head. Grade 2 to 3, brachycephalic, inspiratory stridor, panting, and so on. But this dog comes in. What will you do? Will you stick to your diary, go one by one by one by one, or will you prioritize this dog? I tell you what I would do, right? I drop my cookies, I drop my whatever talk I had, I prioritize this dog, 1000%. Why? What did happen to us that we do not understand an animal in clear respiratory distress? And this is one thing I want to explain to you today, why we must prioritize still these dogs, although we know they are chronic hypoxemic, okay? I want to explain to you why this is so important. Okay, so I'm sure you are fully aware how many problems they have. I'm fully aware this slide is just the tip of the iceberg, okay? It's just, it got so small, the letters, I could not add on anything else. It would have looked too scary. You would not have seen a word. So we have, of course, the respiratory problems. I'm not sure if you are aware, because of all these ongoing reflux situations, they often tend to have aspiration pneumonia, pneumonitis. Some breeds, like the English Bulldog, French Bulldog, have even collapsed left mainstem bronchi commonly. We have an enormous amount of gastrointestinal problem in this breed. Esophagitis, esophageal abnormalities, reflux. Also aerophagia, they breathe funny, they swallow air, this leads to dysbiosis and so on. Herital hernia, pyloric stenosis, very interesting. We quickly talk about this chronic gastroenteropathies. Now, I'm not sure if you're aware how often they can't sleep, right? Sleep disorders are the second most common reason why they are unhappy. We discussed it. Snoring, everyone knows that. Many people think it's cute. It's not. Sleep apnea. And then we have all these other problems. They cannot even give birth on their own most of the time. They have skin problems with all their skin folds. They have hypertension. They have dental problems, of course, all these malformations, eye problems because of the malpositioning. So it's indefinite just to think about it. I quickly summarized this, right? So they can't eat, they can't breathe, and they definitely can't go fishing, meaning any form of activity, right? So this is sad, and they cannot even rest after all this with a form of a wonderful deep night sleep, having struggled all day long with all their problems. So the big three for me as a medic, of course, are respiration, GI, and sleep, what I need to address, okay? So the most common reason why a surgeon asks me for help in a brachycephalic dog are, of course, gastrointestinal signs. And we are, as a medic, I mean, if a surgeon asks me in the hallway, oh, sorry, my friend, she has diarrhea, Steph, what can we do? I mean, I open my diarrhea Bible mentally and I go through everything, right? This is very difficult for a surgeon to understand what medics think with diarrhea. But of course, a big question is always, why does someone vomit? Why does someone have diarrhea? And this is, again, the tip of the iceberg, because everything, it could be leading to these signs. This is why we separate this as extraintestinal versus intestinal problems. And the workup in every stage, in every time of your life is always the same. Although you might already have the suspicion it's an intestinal region, you must rule out everything else, okay? It is really the most misleading clinical signs, because you might even have a dog with diarrhea in heart failure. So this is really just that we think about this, how this is so linked. So yeah, the underlying cause is 100% completely unclear. This is why I have sometimes a twitching eyelid when I speak to a surgeon about diarrhea, because they just are completely unaware of my thinking process here. Okay, so what are now the gastrointestinal signs in a BORAS patient? So this is super interesting. So first of all, it's super highly prevalent. It's almost 100%. Let's say every one of the Frenchies has gastrointestinal signs. And this is absolutely my own experience. So Frenchie come because of vomiting and no one is even thinking about it, right? especially if 3 variables are addressed. A Frenchie, he's male and he's obese, they 100% have gastrointestinal signs. Now, this is interesting. The severity of the gastrointestinal signs is linked to the severity of the respiratory signs and vice versa. Whatever is their first, chicken or egg, we don't know. Wow, this struck me. How can that be? These are 2 different compartments, literally, right? Upper respiratory problems and tummy, where is the link? And now this was also interesting. These clinical signs improve in almost all cases after surgery of the respiratory tract took place, upper respiratory surgery. How is this linked? Let's have a look. So I'm super thrilled by that. So you have this increased upper airway resistance. This leads instantly to an increased breathing effort. You will agree on that. They pump, right? They also swallow air. This increased breathing efforts leads over time to a negative intrathoracic pressure. This is like you have a Hoover attached to your esophagus, okay? You must imagine it like this. And this gets worse over time because the respiration usually gets worse in these animals as well, because over age, the connective tissue gets more lax and so on. This is what we are all fighting, right, with our spores and everything in humans as well. But this is a normal connective tissue getting more lax over time, and it's getting worse, right? And over time, this gets even worse. So everything over time is getting more inflamed. So this means it's a vicious cycle. The breathing efforts gets bigger, they swallow more air, and negative pressure in the thorax is getting more, and everything is more inflamed, and then it starts, right? Over time, it takes quite some time to see actually gastrointestinal symptoms. I'm not sure if people are aware also how many cases with IBD, for instance, have neither vomiting, have neither diarrhea, or have neither reflux. It takes ages to develop, sometimes years, okay? But this is the way. And this, I think, is super scary, right? How many, just thinking about pressures, what effect it has on organs, okay? Now, this was also a very interesting thing. So now let's start with the esophagus. For me as a medic, this is, of course, of highly interesting situation. So there was this, and many papers mentioned that there was they did detect in these brachycephalic dogs esophageal deviation. This means the esophagus is not running straight, it's running in curves. Many people did diagnose this in apparently healthy, whatever healthy is in these breeds, in healthy dogs. They had no gastrointestinal signs, but they also diagnosed in cases who had gastrointestinal signs. Some found that they had some funny vessels. There was a few cases, and they were a bit differently. This is also known in these breeds. This is sometimes some arteries and so on, anatomical differences. They did cut this and it was fine. But more and more cases did diagnose it to be there and has apparently no effect. So many people did report this now, that some consider this also being a so-called primary abnormality, what we have said, like tracheal hypoplasia, nostril stenosis. So this is something what we should consider, and also what you could have as an endoscopy finding. I don't know how much this means for me as a clinician, because as I said, some had signs, some don't, but it's definitely not normal. Okay, so this could mean that maybe the motility of the esophagus, which is rhythmic contraction, might be hindered because it's running in curves, right? This might already make a possible reflux situation worse. Okay, so this is something to remember. Thinking about the Hoover attached to an esophagus, it is not a surprise that almost all, many reflux cases in these cases have a hiatal hernia. And there are so many degrees that it's almost impossible to always diagnose, okay? So hiatal hernias, as you all know, they can be congenital, they can be acquired. And it has a very high prevalence reported in especially French Bulldogs who are Boas patients who have a clear Boas problem. Okay, don't be alarmed that it's always a Frenchie. It's just a breed which has often been used for studies, right? It does not mean that all the other Boas patients don't have that. It's just, I don't know, for whatever reason, people love Frenchies, and I think it's just a high number available. So this is why they use them for this breed. Okay, so think about again, to hoover at the esophagus, all this negative pressure, and then of course they have a sliding hernia, right? So this makes absolutely sense, and it's easy to be explained. What are the consequences? The consequences are a problem. Gastroesophageal reflux, esophagitis, and of course the motility is instantly reduced in these cases as soon as there is an inflammation, triggering more reflux, triggering more inflammation, and then it goes on, vicious cycle over time. Add on to the sliding hernia, which is the most common type. It's super difficult to diagnose, right? You might easily miss it. I might miss it on a scope. So officially, it is a fluoroscopic swallowing study. This would be gold standard, but even then it can be temporary. Maybe it's not there. Just to think about it, what you can do. Endoscopy could work out, but you can also miss. I did scope some, I missed them, and then I saw them in fluoroscopy. Radiographs in contrast, difficult, right? Because they are sedated. So for this usually, or not sedated, it depends what you can do, right? So whatever works. Okay. Needless to say, so we are still in the esophagus, right? We have not even reached the stomach, all these problems already, just the esophagus. They are also known to have an esophageal dysmotility. This means the esophagus is not contracting with the same rhythmic and in a rhythmic contraction, but also not in the right order. So when you swallow, it starts in your upper part and goes further down until the cardia and into the stomach. This is not always happening in these brachycephalic breeds. They swallow and then it stops somehow, or there is a too short swallowing phase, there's different swallowing phase, and so on. We call it dysmotility, okay? This can lead that food is staying much longer in the esophagus than it should be. Some waves are prolonged and so on. And this delay leads again to, because the cardia is open already. The cardia is opening as soon as food is halfway through the esophagus, right? This again leads to reflux. Okay, this is making things even worse. Bless their soul. Okay. So what are causes here? Of course, we can have a primary problem. So just the esophagus is just not functioning, right? But of course, all the other known problems, what we have in these cases, the deviation, the laryngeal paralysis, the reticular fistula, all these things, herital hernia, reflux, and so on, this can all happen. I want to point out, this is interesting. There are several cases that also, they are often have a delay in maturation if they are under 1 year old. Okay, so then they have similar signs like newborn babies. You know, there are some babies who vomit all the time. Okay, and this is, we believe now, because they have a delayed maturation of the esophagus. We believe this is also happening commonly, especially in brachycephalic dogs, when they vomit and vomit and vomit. Often they already know that they did vomit milk before they were even having still on milk with being the mother and so on. This should get better over time. Usually we say the esophagus is mature with 1 year of age. Okay, so sometimes it just takes time, we need to overcome. Okay, what is happening here? Of course, again, gastroesophageal reflux and esophagitis are consequences. Needless to say, we are all on the same boat. This is happening now repeatedly all the time. And the problem is, like you might know from West Highland White Terriers, the more often you have a mild form of aspiration or even tiny little drops here and there, this could lead to a chronic mild aspiration pneumonia, and eventually what is the end consequence? What we see in West Highland white terriers, to a lung fibrosis. Okay, so many dangers with all this. Okay, and just because of an esophageal problem. Okay, so we don't get out of this, so we really have to think about the esophagus and especially esophagitis. As discussed, esophagitis will lead to more reflux, more esophagitis will lead also to GERD, and so on, gastroesophageal reflux disease. It is not an independent disease. This means it's most of the time linked to something. We don't have diseases which are linked to the esophagus only, except there's one exception. What we know in dogs, there's one form which is we consider primary, which is the eosinophilic esophagitis, which is sort of an allergic form. They respond to steroids, and they also need food allergies. Very rare. I've never had one. Okay, so what are the major causes of esophagitis in dogs? It's reflux, and it's a peri-anesthetic reflux, so during anesthesia. These are the two major forms why we have esophagitis. And of course, protected vomiting, when you vomit and vomit, needless to say, in Herital Hernias. Also, of course, recumbency. This means also for prolonged surgical procedures, not only to the anesthetic only, and of course also neurological patient or whatever patient you have, certain drugs, doxycycline, clindamycin, right? And of course, cancers. Okay, gastroesophageal reflux, I've mentioned this now so often, so I'm afraid it's time to discuss it. I'm really passionate about this because I think I missed it so often in my patients. And now, since I'm aware of this, I would say almost all of my gastro patients has this. So, and the more I speak also to humans who are affected by this, the more I think I'm on the right track to take this really more seriously. So gastroesophageal reflux disease is really a multifactorial problem. So we know now in humans that this is most common due to a lower esophageal sphincter incompetence. So this muscle is just not closing properly, or it's increased to an increased pressure in their abdomen. This can be due to pregnancy, but most common, it's due to obesity in humans. Okay, this is why as soon as you have reflux, your doctor will tell you you have to lose weight. Okay, this is the most common reason. The problem is that the incompetence of the lower esophageal sphincter can be linked to several pathologies, right? So again, also in humans, it could be due to a decreased pressure in the chest. It could be linked to so many reasons. And this is, of course, what we try to understand how this affects also our dogs. Interestingly, in humans, how do they diagnose it? They have the best of times because their patients just speak, because 70% of these cases have no endoscopy by 70%, yeah? So what they do is they get several pages long questionnaire. I had to peek. It's so, I mean, what a life is that as a doctor, right? You ask a patient, do you have that? They say yes or no. What tests do we need to do? And they don't reply, okay? So they do all these questionnaires, and this is to understand what are the true clinical signs. And I would so love one day at least to ask a dog how they feel about all this. Okay. Esophagitis, it is almost incredible. And gastroesophageal reflux, so this goes hand in hand as discussed. So they have the same clinical signs, and the range is indefinite. I just summarize it like this. So it's clinical signs and severity vary so widely. It could mean you have no signs because they just don't show, especially in animals who live in multi-pet households, right? As soon as there's a bit of a pack dynamic, animals often tend to show less signs, just not to attract too much attention. They can have severe signs. They can be immediate or delayed. Now, this is important. If you have a peri-anesthetic situation, that there's a reflux disease, they usually have esophagitis signs 5 to 7 days later. My goodness, right? And even the aspiration pneumonia, this can be even more later, right? So these are things which might be linked, but this is how long it takes to expect any form of signs, right? So this might be linked directly to your anesthetic problem, and you are maybe not aware of this. Yeah, the esophageal, the eosinophilic esophagitis, they also often have skin problems, just to be complete here. Okay, so if esophagitis clinical signs would be a movie, I think I would really call it Never Ending Story, because really literally everything is possible. And now, since I'm thinking more about brachycephalic dogs, I think I missed hundreds, thousands, maybe I even thought they have kennel cough because they did vomit all this frothy material. Maybe I thought they had tracheitis. I admit I missed them. Yeah, I'm now thinking much more differently, because I ask, when are these situations? Are they linked to exercise? Are they linked to food? Are they in the middle of the night? Classic signs would be, especially like in humans, think of heartburn. I hope you never had that. How is heartburn? It's usually in the night. Why is that? The whole sympathetic, parasympathetic system is completely changing, and you are usually, as a human, of course, you are in the lying position, which of course makes it easier for reflux. And this is also what happens to dog. They are resting, they are more lying on the side or whatever, and this makes it all easier. Add onto the parasympathetic situation. So what is classic to see for reflux is often they have an overextended head, they swallow dryly, maybe they drool, they vomit, maybe they vomit, maybe they just do grass eating, surface licking. They often, it's really almost distinguished. They try to overextend their head, and I thought often maybe they have a bit of sore throat, or they have but I had one referral. They came because they thought the dog has neck pain. It came to neuro, and they treated for half a year with gabapentin, actually. And it's just, the dog had just reflux. I gave him Omeprazole and other medications, what we discussed, and it was done after 5 days. They thought it has neck pain. This is how severe it is, right? And of course, you can have swallowing problems, and especially always ask when it is. So at the night or after longer fasting periods, things like that, okay? Also painful swallowing. So there's also a bit of a distinct thing in Frenchies, of course. So they have especially linked to exercise. Sometimes this reflux, right, is because of the increased breathing effort sometimes. And again, the negative pressure gets worse in the chest. And so often they have this mix of regurg and retching. And often, again, this white frothy material, which I always thought, all right, maybe where is this coming from? Yeah, but it's from the esophagus, okay? Secondary signs of esophagitis are then this increased hoarseness, because of a laryngitis. You might get sneezing because of a rhinitis with all the reflux every time, cough, of course, aspiration, pneumonia, and eventually even lung fibrosis is possible. I love this about humans. So they have a wonderful thing, and this took my breath away, I must say, because they have the Montreal definition of gastroesophageal reflux. And I want to point out that in humans, they divide this in esophageal problems and extraesophageal problems. So everything what is linked to a classic reflux is basically here on the left-hand side. So of course, you can get eventually even a stricture or even cancer in humans. So adenocarcinoma is well known, linked to chronic reflux disease because of the chronic injury and all this, this horrible chest pain syndrome, right? Like heartburn, basically. This is the official term. And I wonder if our dogs also have this sometimes when they are really, really that painful. But now here it comes. Look at that. Extraesophageal symptom. So what are established associations in humans and what are proposed associations? Look at this. So the reflux cough syndrome, cough is the most common reason for presentation of humans for reflux. Humans have as a clinical presentation most commonly cough, just because of their anatomy where it's linked, right? This is crazy. Laryngitis is known. Asthma is known to be linked to reflux in humans, and dental erosions, right? Of course, the reflux is destroying their teeth. Now look at this. Pharyngitis, sinusitis, pulmonary fibrosis, and now look, recurrent otitis media. Ever had a Frenchie with ear problems? Yes, hundreds at least, right? Could this be linked to reflux? Yes, absolutely. It's impossible to diagnose this, right? Your Eustachian tube is here in the pharynx. Reflux can go in. Maybe this is the reason, not only the narrowed ear canal, maybe this is all adding up. What is all this? Just because of reflux. See these links. Think about it. Don't forget that. How many problems could be linked to one another? It's a whole body approach after all. Okay. So how do we diagnose this? Yes, this is why you are here. Yeah, I'm sorry. This is a bit sad. Of course, it makes sense to understand that the earlier we know it, the better, right? So the better the treatment, the better the outcome. Of course, we try to rely on clinical signs. Of course, it would be so easy to do a scope, to find all classical findings and do biopsies, but I'm afraid since the esophageal mucosa is a conified epithelium, it's very unrewarding. So all the samples you take are usually, they say, oh, it's only superficial, it's not deep enough, they won't tell, it's only conified epithelium. So this is why no one is doing it. The danger, of course, is also if it's super inflamed, ulcerated, that you might even perforate. In this case, it's not so thick as our intestine, right? So it's really, really not easy. So it's only theoretical. Officially, again, you would need radiofluoroscopy, contrast studies and so on. And wonderful, of course, is the Bravo capsule, which is measuring the pH in the esophagus, which as far as I know, is very expensive. I never used it personally, but of course, in theory, this would be amazing to understand if there's reflux, right? You measure the pH, is the pH acidic? Then it's reflux, okay? And of course, you must rule out everything else. This is how we basically watch this. I know it's said you are frustrated. No, I'm afraid not more to offer at the moment. And yeah, last but not least, always our response to treatment, and this is basically sort of my approach. I'm not sure if you have ever seen pictures of an inflamed esophagus, how this could look like. It could be super subtle signs, but again, don't forget, you could also have no signs at all. Why is that? Why is this in humans that they have no signs at all? Because they say the upper epithelium is damaged in such a way that the tight junctions between the cells, which hold these cells together, are destroyed, and all the acidity is going underneath. So on the surface, it looks normal and all the inflammation is underneath. This is the theory behind it, why it looks normal in so many cases. So never forget that, okay? So how does this look? Of course, on endoscopy, what you would in ideal world see to understand this, it's of course depending on how often was the reflux and which type of reflux. Is it more bile? Then it's of course even more aggressive because bile contains digestive enzymes. Then it's getting really unhappy. How is the frequency, contact time, and so on. And of course, needless to say, it's mainly in the caudal thoracic esophagus. Okay, you can have any form of reddening erosions. It can be swollen. You clearly see it's distinct. It's so I very rarely had bleedings, but it can be verifiable as you just go in with your scope. It can already bleed. And of course, it can also be a stricture or structure formation. So you can have nodules, but also cause a stricture is also possible. Worst case end stage scenario. It's always important to note if there is a closed or open cardia. Okay, cardia should always be closed. As soon as it's open, it's pathological for us. We want that this is closed. Okay. Okay, so these are things to recognize it. So how would you treat this now? It makes absolutely sense if you have the suspicion to try in any possible way to increase this lower esophageal pressure because we want the stomach sealed, we want it closed, okay? At the same time, I know that this will be almost impossible to achieve exclusively. I also try to reduce the pH in case the reflux gets worse. This is what I need to do all together, okay? So first of all, I try to understand always in this workup, again, it's the tip of the iceberg, what are the predisposing factors, what else is going on? Now the question is, since anesthesia is such a big trigger for esophagitis, what shall I do pre-treatments before surgery? And this is really disappointing. I'm afraid there is no consensus. We know with the best possible treatment, and this is the best, what is the best? They give Esomeprazole, so not Omeprazole, but Esomeprazole, which is considered much more potent than Omeprazole in these cases, and also cisapride as a anti-nausea medication, which is having a particular effect on the lower esophageal sphincter in these cases. And the sad thing is, none of our protocols could ever prevent a reflux problem. They could, however, reduce the severity and frequency, but none is working. Officially, of course, it takes also quite some time for omeprazole to be effective. So giving omeprazole during your procedures, hardly any effect. Ideally, you even start the day before, 12 to 24 hours before, and then, of course, also again before your procedure. But again, as I said, it's not stopping you. It's all about management. Having also the patient maybe lying a bit higher in the front, that there is, gravity, thinking like this, having not too long in recumbency. These are things which are much more important, I'm afraid. So there's no medication which stops it. This is already something what we know. But we know one thing for sure, that the better the patient is breathing long-term, the less reflux I have. So airway surgery is the key, okay? So this will be long-term the most reliable measure you have to avoid more reflux and to avoid obesity. Obesity never helps, especially not in a brachycephalic dog. Again, think about the pressure from the abdomen on the lower esophageal sphincter with overweight. All esophagitis cases benefit from something highly digestible and benefit from small frequent meals. The less pressure is in the stomach, the less the stomach is filled, the highly digestible, the better, okay? What are medications? Okay, I know you are keen to give something, and I totally feel for you. I would do the same. It's not only what to give, it's also how long you give. Okay, so yes, omeprazole is #1 treatment here, and I know you are eager to read that. The other thing to increase this lower esophageal pressure is the cisapride. Okay, we give this up to 3 times daily. It's super important not to forget the following. Omeprazole is lowering the gastric pH. It leads over time, if you give it for too long, to a gastrointestinal bacterial overgrowth and can even lead to dysbiosis and malabsorption of many nutrients. This is not a medication which we give long-term. We don't do that. We give it short-term to see if there's response, and then we might reset it and stop it in between rather than giving permanently. We have a lot of problems here if we give it for too long. The acidity is sinking too low, okay? It's also important to note that the dosage is officially twice daily. Once daily is not enough in dogs and cats. The acidity with once daily dosing is anyway only reduced to 3 to 5 hours, but you need longer to lower the acidity already. Sucralfate makes only sense if there are alterations. Before that, it doesn't make sense because it needs the exposed mucosa to be activated. And you might even trigger more aspiration if you do all the liquid stuff with them and they don't like it, and you fight it only if you think there are alterations. Okay, I'm not sure how you feel, but we have not even reached the stomach yet, and we're talking about the esophagus, so it's time really for a deep breath for me, right? To think about what we have just spoken about, and really, it's just the esophagus, right? We have not talked about anything else. Okay, something easy for a moment. So, as discussed, these respiratory problems, the more severe it is, the more severe are the gastrointestinal problems. There were many smart surgeons who had basically BOAS patients, and they did, because of the high prevalence of gastrointestinal signs, they just scoped them as well at the same time they did their BOAS surgery and so on. And they found all these findings. So several colleagues basically found they had lymphoplasmacytic gastritis, duodenitis as well. So my problem, or our medical problem with these cases, is that lymphoplasmacytic gastritis, duodenitis does not mean anything to us medics, because the gastrointestinal tract is responding stereotypically to every insult. This means a food allergy, an antibiotic responsive disease, and IBD could have a lymphoplasmacytic inflammation confirmed. This is just a sign that there is a chronic inflammation. And we don't know, because many of these cases had no clinical signs, that this actually was a problem in this particular case. So these studies are important to mention, that there are problems, but for me, there are many limitations. So I need a stepwise approach to find out what the underlying causes. This has not been done here, but I acknowledge that so many cases had chronic stomach and small intestinal inflammation confirmed, and this is what we should keep in mind. Almost there, we almost through the gastrointestinal tract, don't worry. Other problems, of course, they swallow a lot of air. Swallowing of air, of course, leads to flatulence, which is sometimes considered a bit funny to owners, but of course, this bloating, again, is leading to more pressure in the abdomen, and again, to more reflux, right? So we try to avoid that. Again, airway surgery, but also swallowing of air means that the wrong bacteria could overgrow over time and also favor bacteria which produce more gas, right? So these are things to consider. It is also a management problem to avoid gassy food. So often they, of course, get, it's really important to have a high digestible food, for instance. Sometimes they even respond then to antibiotics. So sometimes I put them on metronidazole, for instance, to reduce the bacterial load. They often respond because they have already dysbiosis. Some breeds, especially Shih Tzu, have also known pyloric stenosis. So they have, to whatever reason, hypertrophy of the pyloric mucosa and muscularis, and they have then like obstructive vomiting. It's surgical, but you can't basically, but it's really bad prognosis if you see that. It's quite intense. It's very sad. And of course, we all know that, right? The Chronologumatous Colitis, which is linked to a very aggressive E. coli infection, in especially boxers, Frenchies, and Mastiffs. It's a severest IBD form. They are really, really ill, right? We know now that there must be a genetical problem, that they are more susceptible, that E. coli can invade these cells. I'm afraid, although we know fluoroquinolones are #1 choice, most of them are resistant in the meantime. So much has happened. However, despite their known resistances, and we do then this FISH analysis, I'm not sure if you've heard of this as a test, which works, that still many respond despite a proven resistancy against this. But I'm afraid still always try it in worst case scenario. Okay, so this was only about the gastrointestinal tract, and I swear there is so much more literature out there. What is going on? And it really makes me sad. Now you think, okay, you have a patient, he cannot breathe, he cannot eat the whole day, so at least he deserves a good night's sleep, right? So this is what I thought, and I was not aware how much drama is involved here as well. So yeah, what's about sleeping in these breeds? And this is really, I was really not aware. So of course, as soon as you have a upper airway resistance, you tend to snore. Even when we have a cold, right? We snore. You think this has usually no effect on you, especially if you do it maybe not permanently, or maybe you don't think about it. But what happens over time when you snore is that this can progress and can lead finally also to a sort of obstruction, which then also could lead, I'm afraid, finally to the apnea situation, that you have a breathing stop. So it is very common in brachycephalic breeds, and there are studies in dogs even who owners thought they have a good night's sleep. They don't. They have a high rate of sleep fragmentation. And we summarize this in sleep disordered breathing patterns, like in humans. This is actually so common in dogs, and especially the English Bulldog, and it's so similar to humans that the English Bulldog is used as a model for human sleep apnea. This is how severe it is. So as the BP is basically combining the snoring situation with the obstructive sleep apnea. We have two major types, and this is the central sleep apnea. This is central, means your brain is telling you for whatever reason not to breathe, so you have a breathing stop for a moment, and you have the obstructive one to whatever reason, and of course you have mixed ones. We know in dogs it's mainly obstructive. However, there are more and more cases when we think it's also central. So like a mixed one. And basically what you can see here is the most important reason in humans for an obstructive sleep apnea is that they often also have an elongated soft palate. So, and if this is to whatever reason blocked, then you basically don't breathe for a moment. Okay, this can be total, this can be partial, this can happen during the day, and this can happen during sleep, of course. Obesity is the biggest problem in humans, why they have that. Okay, so it usually the progress, as you see here again, is that you start snoring, and over time you breathe less, your breathing effort is less, and finally you have a breathing stop. This leads to a state of chronic hypoxemia. Needless to say, you don't breathe, right? And now the question is, what systemic effects are linked to this? In humans, it is enormous. Lack of sleep is the only true pandemic we have. The only truest pandemic in this whole world. And it's linked to accidents, it's linked to strokes, it's linked to stress, it's linked to cancer. All sleep. This is why the WHO always has it as a disease listed, lack of sleep. Imagine. Okay, now we have created here a problem. We have a malformation in a dog, and we created the problem that they can't sleep. This was interesting to understand the histology of the soft palate, because of course the soft palate is elongated, right? And I was wondering what is the problem here, and I thought it's elongated because of a muscular problem. I was not aware that there is quite also a abnormality in the histology findings. So basically I was thinking, sure, this must be sort of a muscle hypertrophy in these cases, but it's not. It's actually just a thickened superficial epithelium. There is no function, and it's a connective tissue layer, right? There is no function at all in this elongated soft palate. And this is also a problem, just to keep this in mind, which leads to an additional malfunction, which makes all this breathing worse, which makes all this obstruction worse, because it's not a muscle, right? The soft palate is supposed to be a muscle layer because it's moving with the swallowing. If it's not a muscle, then this is not functioning properly, right? So this is just to understand this whole situation, what makes everything worse. This was also something what I thought is important, or it was quite interesting. There was a group, they examined dogs with rhinitis and also signs, and they also did basically the same problem study what they did before with the with just scoping. They basically also scoped the gastrointestinal tract at the same time, and they found out, so again, same limitations, right? That most of them who had rhinitis also had gastrointestinal findings, lymphoplasmacytic inflammation, adding on to this reflux finding, adding on to this inflammation of the soft palate. Okay, this is just one additional point I wanted to make. Okay, but going back to the sleep apnea now. So what do you have? It makes absolutely sense. You have chronic hypoxemia. This can be intermittent, can be permanent. Of course, at the same time, lack of breathing, CO2 will go up, hypercapnia. Okay, oxygen is you comes in, CO2 doesn't go out. We know now in these breeds that they chronically have a lower arterial pressure and oxygen, makes sense, and a higher CO2 makes sense. Now, interestingly, most of them also have a higher PCV than other breeds, higher reference ranges. This we think this is to compensate this lack of oxygen. Okay, now most of these breeds also have hypertension, higher arterial blood pressure. This has been proven in several studies, and it has been proven and directly linked to sleep apnea in humans. We don't know 100% why, but we think it's a multifactorial reason, because when you don't breathe, your whole sympathetic system kicks in. This is stress. Your body thinks you are dying, okay? So they kick in the RAAS system, they kick in the sympathetic nervous system. So stress hormones are released. And this is why they believe over time, this leads to a systemic hypertension problem, right? In humans, we know it leads to inflammation as well, metabolic dysregulation, and so on. There are so many things linked to this. Okay. One thing we do know though, hypertension and sleep, how could this be linked? There is something interesting. We know in humans that most common people with sleep apnea have a deficiency in magnesium. Magnesium is an essential cofactor for many, many things. Basically, every essential step almost in the body, especially also the Krebs cycle. I'm afraid the problem is it's mainly intracellular, right? We can't measure it properly extracellularly, right? In the plasma and interstitium. We still don't know how to measure it reliably. We are just guessing. It's the same, you know, when you measure calcium, you measure total calcium and you measure ionized calcium. And this is what we do with magnesium, is where we measure total magnesium and ionized magnesium to get an idea. But as I said, it's mainly in the cells. We don't know if there's a deficiency on cellular level, okay? We know that a chronic magnesium deficiency is very common, and it has also been confirmed in healthy bulldogs. Healthy means here they were not considered as a BOAS patient. They had no abnormal breathing, and despite that, they had a low magnesium. Okay, and this is linked to so many steps. This is starvation on cellular level and energy level. Okay. Sorry, one moment here, just quickly. Okay, so what are all these consequences? What is linked to all this here? Okay, there are several studies out there. This really freaked me out a bit, because we know how much inflammation is linked to a lack of sleep. And maybe tonight you will have a wonderful good night's sleep, and I wish you that, because when you hear all this, you don't want to miss any hours sleep anymore. So what they did, and this was an interesting study, they measured with elastography. So elastography is a ultrasound technology to measure a firmness of an organ. So it's non-invasive. The firmer an organ, the more you know how higher the grade of fibrosis is. In humans, they use it to detect liver fibrosis. And what they did, they tried to do the same with dogs, and they measured in those BOA patients the liver and splenic stiffness, and they were all higher, right? So this confirms BOAS dogs have a higher stiffness in their organs. And I'm sure I even had referrals for that. You had occasional cases when you were wondering, why is my BOAS dogs the ALT higher? Yes, the ALT is an hypoxic marker in the liver. And this is linked because the dogs can't breathe. And this is why often the ALT is higher, right? Because of that and because of the ongoing damage due to the hypoxia, okay? In this study, they also found they confirmed that this is a systemic inflammation, metabolic dysfunction, and so on. They found higher leukocyte numbers and so on. And they also suggest that there is a suspicion of a sort of metabolic syndrome, meaning metabolic syndrome is a term we use in humans. It's the combination of obesity, diabetes, or pre-diabetic state and hypertension. Frenchies or obese brachycephalic dogs often have also pre-diabetic state. So this means the resting glucose much higher. We think it's also linked to the stress what they have. So glucose is upregulated as soon as adrenaline kicks in, which we have with the hypoxemia again, right? What severe effects do you have just because you can't breathe? Another study here showed how many more parameters are elevated. Again, glucose was higher in this study, fructosamine was higher, long-term sugar parameter, right? Cholesterol was higher, CRP as an inflammatory non-specific parameter was higher, triglycerides, cholesterol, lipoproteins, and so on. This again confirming a generalized inflammatory response and metabolic derangements in these breeds. This is severe. This is really severe. This also is scary that they are more hypercoagulable, right? So coagulation is linked always to inflammation. Coagulation and inflammation go hand in hand, right? So as soon as you have a severe inflammation, you might have also an increased risk of coagulation. And this is also linked to severity of BOAS patient. And now this was creepy in this study that also unaffected dogs, so again, dressed actually quite normally, also had increased coagulation. Oh my God, right? I mean, what is all wrong here? They also found that there is a delayed fibrinolysis in BOAS dogs like in humans. Okay. So how can you treat sleep abnormalities, right? Yes, there is, this would be also a personal question, of course, I have. Weight loss makes sense, right? Always. And airway surgery. again, makes also sense, right? I was hoping there would be some other stone of wisdom, but there is something what literature tells us, and this is what they copied from humans as well. Ondansetron, who would have thought, which is actually what we use as anti-nausea. It is a serotonin antagonist, and I skipped a lot in the obstructive sleep apnea story. There is actually an enormous neurotransmitter, neurochemical science behind this. This is why in humans you have sleep scientists, you have sleep doctors. There is so much information going on about this. So, and this is one step they think they can control, especially in central sleep apnea, where they think serotonin has a huge impact. It's a neurotransmitter, and this is also important for serotonin. It has a huge impact on the upper airway patency and respiration during sleep. So it is used there in this phase of our sleep to a more effect on these muscles. So if this is why it's so important, this is why they think this is linked. They realize in this sleep breathing patterns that this is clearly reduced in REM sleep in bulldogs, and they realized that so REM sleep is when rapid eye movement phase. This is the phase when you dream, right? I'm not sure if in sleep you are aware that there are several phases, and there is this rapid eye movement phase when you sleep. This is when you consider your night is a resting, you had a resting night of sleep. You usually had a lot of REM sleep. Okay, rapid eye movement phases when all your eyes go wide. It's crazy. And what they did is they noticed when they gave English bulldogs ondansetron that they had the feeling the REM sleep was longer. There was also another study, they gave a different dose. I don't know these dosages. There is nothing published about this. These are just studies I found. I cannot give you a full recommendation, but I think there's no harm done trying it, because this is a dosage you would also use as an anti-nausea medication. And as we have seen with the gastrointestinal problems, anti-nausea is definitely also indicated in this patient for sure. So feel free in a sleep patient to try this, because I think it's definitely safe, right? So they had reduced breathing episodes and they slept better when they got ondansetron, right? It's not officially out, but this is what I can offer. And this is the only thing I can offer from medical point of view. Okay, we are almost there, okay? This is really a historic day today, because a medic tells you that we need surgery first. Okay, I would have thought I would say that, but I'm telling you now, in these cases, we need surgery first if we want any improvement from medical point of view. I have no magic potion, sorry, and no superpowers today, but this is the baseline, really the baseline of therapy, okay? Everything without surgery is, I consider, palliation. So it's palliative therapy. And this is how I also communicate to the owner, right? So it's only considered to be temporary effective. And I will never ever cure this reflux problem with the gastrointestinal problem in dog if I don't at the same time treat the respiratory tract. Weight is the only thing what must be controlled indefinitely in these dogs. Indefinite, they must have the best weight, not due to cosmetic reasons, due to medical reasons, okay? And I clearly tell them that the first thing usually they get on a weight loss program. And with my full heart, I think we vets, it's our responsibility to correct this perception in a BOAS patient that this is all normal, right? This is a man-created problem. And I hope with this talk, I could show you how much is linked to this, how much they suffer. They are chronically inflamed. They can't breathe. Again, they can't eat properly and they can't sleep. This must stop. And I hope with this talk, your perception and maybe your reaction to this trait is different. And we all agree the next BOAS patient who comes in our treatment room will always be prioritized because they have so much on their plate. They deserve to be priority at all times. Okay. Thank you so very much. And I really appreciate that you have been here tonight in your free evening, hopefully, and not a night shift. And yes, I'm sure you have many questions. Thank you very much.
Thank you, Steph. I mean, wow, that was an eye-opener, wasn't it? yeah, really, really interesting. Thank you for that, Steph.
Anytime. Thank you.
So yeah, we've got some time now for Q&A. So if anyone has any questions, please do send them through on the chat box. And also you can send over through WhatsApp as well. So we have had one question. So from Zoe, we have how do I actually tell the proud new owners that their dog of a brachy, that their dog is likely unhealthy and is not normal?
It's a very good question, and I'm stumbling over this question all the time. It's just my only luck is that I see them, excuse me, in a later point of view of their life. So they are already ill and the owner knows they are ill. It's just I would, of course, we have to be diplomatic. And as I said, the owner is the key here. I must really make this owner aware. I try to use my scientific data, what I have. So I said already, just listen to the sound. You don't hear this in other breeds. So this I explained already, that you already hear that there is a turbulence, and turbulence means irritation. So this is how I try to explain it often. And this is what we, that I try to explain, but it's I totally agree. You can, as a vet, you can only lose in these discussions because the owners are reluctant often at the beginning. They only listen as soon as the dog has a problem, right? When they had the first syncope, or they had any other form of adverse event which was linked to breathing, or a heat stroke or things like that. Slowly they understand. I agree. This is very tricky, and on purpose I wasn't scratching too much on this, but it's just also because the owner, as I said, is a different owner than from an average dog. They take into account that this dog they know that they have a breathing problem, or they even tell me sometimes, oh, it's a special breed, he's breathing better. I still think, well, it's still 70% of the nose is missing. Now he has 10% more, right? It's better and the tendency is right, but wow, during lockdown, I was shocked. I'm now getting, in this phase of lockdown, I'm getting more and more puppies, brachycephalic puppies. I'm not sure how it is for you guys, but which have enormous problems, right? I'm sorry, I cannot give you with all my heart here a good answer. I try individually to address this to the owner, what I think would work the best. But now maybe, I hope with this talk, you have more evidence to talk to them and just make them aware how important it is to have weight loss in place, consider early gastrointestinal signs as already a reflux sign, and recommend surgery as early as possible for breathing. This is my advice.
Yeah, thank you, Steph. And hopefully, as time goes on and the campaigns that are out there, we'll hopefully see
I hope
people noticing before they've got their dog with them. We've got another question, Steph. Would you advocate not neutering brachycephalic breeds to reduce weight gain?
Look, I would do everything to reduce their weight. So if in general, if this is a very affected brachycephalic dog, they should not breed. Right? It's a congenital disorder. So whatever works for this patient, I'm happy to support everything. If you want for the rest of the life have chemical castration, go for it. If you and try this, right, as a temporary solution. But we all know that castration has an effect, for instance, on the weight situation, but it's not a 100% link anyway. So I would look individually if it works. But the worse they breathe, the worse it is a congenital malformation, so they should not be bred, right? So this must be clear. There is also no right or wrong answer. Again, it could be individually more indicated, and yeah, it's whether they breathe again, the more they will move, the more likely they will be less obese. Consider respiratory surgery and maybe castration at the same time. So this would be a middle way. Yeah, this is what I probably would recommend, despite all drama. Oh, sorry.
Thank you, Steph.
Anytime.
We have another question. So if a patient improves significantly on omeprazole, how frequently do you give the omeprazole courses, and for what duration to avoid the dysbiosis?
Good question. Absolutely. I was waiting for that. So what I usually do if I have a high suspicion of reflux, of course I start on omeprazole. I try not to go over a 10 days course, right? I usually have them only on a week or so on medication. In this time, I changed the dietary management, feeding small portions, highly digestible. And then after this week, I usually stop, for instance, first the omeprazole. I do a bit of overlap. I stop the omeprazole first and have them on a cisapride for only 2 or 3 days longer, so that I have not everything cut off at the same time. So I'm increasing the sphincter a bit longer, right? And have at the same time the dietary management in place, and then I stop and see how it goes. Most of the time, actually, this is already enough. And really, I swear to God, therapy is done after a week, 10 days time, or I start them as an exchange, sometimes on a cisapride again, and give, for instance, a cisapride instead of 3 times daily, only twice daily, or maybe even only once daily. And it's just so I taper it down, right? So I try to balance this a bit. The omeprazole is under big examination in humans, and now more and more, I'm not sure if you read some literature in veterinary medicine, because it's permanently overprescribed in humans. And we know now in humans, because they take it over years often, how often severe the impacts are. We think now we do with antacids actually more harm than benefit. So the shorter you give it, the better. So if surgery is not an option, so the next step for me is surgery, right? The reflux, as discussed, the Hoover and the esophagus is there because of the respiration problems. So I try to push them into surgery, I must say. So I try not to overuse it.
We have a couple more questions along the line of the kind of omeprazole and ondansetron use. So someone has asked, would you use ondansetron and cisapride together?
Yeah, no problem. Yeah. Oh yeah. Oh yeah.
Great. Another one was, do you advise using metoclopramide as a prokinetic for long-term reflux control?
Metoclopramide is the same family member as the cisapride. I'm afraid the effects are not so good, apparently, on the lower esophageal sphincter, but definitely has good effects. Apparently, the cisapride is superior to the lower esophageal sphincter in competence. So I would always prefer the cisapride if you can.
Okay. Yes, sorry, go on.
No, it's fine. They also have a liquid version, which I think is sometimes quite practical. I'm not sure. Some prefer that. So just to think about it.
We've also had a question specifically for omeprazole being given so perioperatively, so given before a general anaesthetic. There's a question, is it ineffective?
Apparently, yes. So it takes 10 to 12 hours for omeprazole to be effective. And again, the reflux, so what you achieve is, we know now with one dosage, is that you lower the acidity only for 3 to 4, maximum 5 hours. And you think, okay, I give it only once daily and I reduced it. Now, you reduce the acidity, not like in permanent. It's just reduced only for a few hours. This is why also twice day dosing is so important. So if I have a high suspicion of reflux, so I think there's something happening, I give it the night before and I give it in the morning again, and then I do surgery then 2-3 hours later. This would be ideal. We know that the Meprazole again would be prioritized. So if you have this an injection solution, use this. This is apparently more potent. This is definitely preferred. Same protocol, so evening before and morning, and then I give it IV, right? So just to avoid any more effects, and it's also more potent IV for the acidity reduction. So this is what we would recommend. Yeah, it's very sad, the anesthesia management, I'm afraid. Very frustrating.
Thank you. We've got a few more questions. Let me just have a look what we've gone through. So we've got, what options are there for a brachy dog that has undergone upper airway surgery already, but still has quite severe upper respiratory tract noise?
Medically, hardly anything. I'm serious. It's only surgery. This is malformation. I can maybe give some anti-inflammatories if there are no GI signs, but GI signs are anywhere there, right? So there is definitely an add-on inflammation. There's no medical treatment. This is really one of the few cases, I must say, is surgery first. This is sad to me to say as a medic, but surgery first. It's my personal drama. Yeah.
We have a few questions related to surgery, so I'm not sure if we've already covered those, but we've got a question about the youngest age that they can have VOAS surgery. And so they've said if they have the nostrils enlarged before 6 months of age, will this reduce the chances of needing further VOAS surgery?
Yes. Yeah. So I'm afraid, of course, the earlier you have surgery, the higher the likelihood that you will need another surgery. Just as we've discussed, it's not only the growing factor, but it's connective tissue is changing over time. And also reflux might, of course, affect any form of other tissues, soft palate, inflammation, and so on. So as far as I know, our soft tissue surgeons usually recommend to least wait until they're 3 to 4 months old, right? So until the teething is done, just because there's so much movement in the jaw and all these things. But if they can't breathe, they can't breathe, right? So then it should be done the earlier the better. We see cases in all the soft tissue surgeons who I worked with, who are working with Brachiocephalic, they have often at least 2 surgeries in their life, if not even 3.
Okay, thank you. Hopefully that answered your questions. If you've got any follow-ups, do let me know. We have, so should upper airway surgery only be carried out when clinical signs start to show, or should we ideally be looking at elective procedures with these cases?
This is now, look, the evidence in the papers that normal brachycephalic dogs had already increased inflammatory parameters, were hypercoagulable, and had low magnesium, indicating already the sleep apnea part, right, and hypertension part. First of all, of course, no harm, but now seeing this evidence, I wonder if we should do this rather earlier than later, to be honest. So, but what is, of course, we have these grades, right? They have BOAS grades, and they usually this based on videos they get from doing exercise, or they do exercise tests. And yeah, how subjective is that? So often you have a normal brachy, and then there are situations when they suddenly can't breathe, right? And you have other situations when it sounds like they are normal. So I probably, with the evidence, I must say, I would probably have surgery earlier than later.
Yeah.
Truth to be told. Sad.
It is very sad. We have another question. When feeding a highly digestible food, is there any difference between wet and dry? And do you have a preference?
No, I absolutely not. It's depending on the individual who prefers what they want. Absolutely not. All good.
Lovely. I think that's everyone's questions. I'll just double check on our WhatsApp. But otherwise, I've just got some lovely feedback. So thank you to everyone who's been giving you that lovely feedback.
Thank you.
Zoe.
Thank you.
Yeah, thank you. If anyone's got another question, please do pop it through. Otherwise, I think that looks like it's everything. So thank you ever so much, Steph. Really informative, and such an eye-opener, and such a shame for
it is. And don't be frustrated, people. Really, I'm supporting you. Don't be scared and don't feel sorry. Also, I'm aware that these cases just die sometimes, okay? With this information, I want to show you it wasn't you, okay? It's just because I had very frustrating cases. I thought, why did this patient die? I did whatever, a routine thing, and they just died. And they have thousands of reasons to die, okay? It's not you. And this is what I try to explain to the owner anytime. So, and now you have the evidence, black and white. And this is, I swear, all the papers I did quote here, this was the tip of the iceberg. There's so much more there. I could talk all night long about all the problems they have. Okay, don't feel sorry and don't get frustrated. You're doing an amazing job. Okay.
Thanks, Steph.
Okay, thank you.
Okay, thank you everyone for attending, and hopefully we'll see you at our next webinar.